All right, everyone. How about we go ahead and get started? And then in the meantime, Virginia will also be joining us. So good afternoon, everyone, and good morning to those joining from the West Coast. My name is Hamera Osman, and on behalf of Muscular Dystrophy Canada, I'm very happy to welcome you to our webinar from our new Let's Talk NMD, Let's Talk Neuromuscular Disorders series. Before I introduce today's topic, I would like to mention that we have muted all participants, but I welcome you to type any questions or comments throughout today's session in the chat box. We have also allotted time at the end of today's webinar for a live Q&A. At that time point, you can use the hand raise button and we will invite you to share your experiences, comments, or ask questions of our speakers. Please note, a recording of today's webinar will be made available by the end of this week on our MDC YouTube channel. With that said, let's get started. Today's weekly webinar is on virtual or tele-physiotherapy. As an organization that represents over 160 different neuromuscular disorders, we recognize that pain, muscle soreness, muscle weakness, sleep can be affected in different ways by different disorders. However, exercise and physiotherapy are important parts of standard treatment plans for, I'm just going to mute everyone. There we go. Sorry about that. Exercise and physical therapy are important parts of standard treatment plans for almost all neuromuscular disorders. In fact, it's well documented in the scientific literature that while physiotherapy cannot reverse the disease process, targeted exercises may delay or prevent secondary conditions such as obesity, osteoporosis, and improve general fitness. It's also been suggested that development of deformities or contractures secondary to some neuromuscular disorders can be delayed with physical intervention. Exercises may also help improve sleepiness and help manage pain. In one study from 2013, we learned that physiotherapy services not only provide physical benefits to adults with neuromuscular disorders, but there are also non-physical aspects of treatment that are really valued by clients. Adults with neuromuscular disorders noted that attending physiotherapy helped to motivate them to be more proactive in carrying out their exercises and helping themselves. Others mentioned that physical therapy helped them get pain relief or cope better with pain. 41% of participants identified psychosocial benefits, which really means they found that physical therapy improved their general well-being. And that was one of the reasons why they attended weekly physiotherapy. For some, attending physiotherapy was seen as a meeting place for social interaction. It seemed that accessing physiotherapy allowed participants to talk over problems and share their experiences, which helped them to cope with their neuromuscular disorder. Some participants identified that attending physiotherapy gave them the confidence that they needed about their disability and helped to improve their quality of life. Now, with these benefits in mind, it's distressing to know that many adults and children in Canada have completely stopped attending physiotherapy for the last 7 to 8 weeks. The Canadian Physiotherapy Association has recognized that in these uncertain times and the need for physical distancing, then remote delivery of physiotherapy is an ideal model to support ongoing physiotherapist services during this period, especially for those who are vulnerable. For that reason, we want to hold today's webinar. We want to understand whether virtual or telephysiotherapy works. Is there science evidence to prove that it can be helpful for those with neuromuscular disorders? What can we do at home to help maintain physical and general wellness? So we're very grateful for our outstanding lineup of speakers that can help to address these questions. In advance of their presentations, I would like to thank each of our speakers for their time and for their expertise. First, we have Wendy Epp. She is a co-owner of Form Physiotherapy in Vancouver, BC. Wendy has over 20 years experience as a professional physiotherapist. She's a function-based physiotherapist who uses assessment tools and movement strategies to help patients in a wide array of sports. A unique and effective feature of Wendy's delivery of care is her use of video feedback as a tool to achieve a level of understanding and movement knowledge in her patients of all ages. I was interested to read that Wendy travels part-time with the Canadian freestyle ski team From 1997 to 2010, she traveled internationally and attended the Salt Lake City Winter Olympic Games as chief therapist for the freestyle team. Welcome, Wendy. I'll go ahead and unmute your mic. Go ahead.
Good morning, everyone. I say good morning because it's just still that way here on the West Coast. And thank you for taking the time. This is a very interesting, I hate to make a curve joke. And normally I'm an incredibly interactive speaker where I gather some steam based on whether you like my jokes or not. So this is a very interesting forum for me to talk through. So I found it ironic that while I was stressing about doing a talk virtually, speaking to a microphone and a screen, what I was really doing was putting myself out there as you would as patients, maybe embarking in telehealth and thinking about meeting somebody clinically in a role that you would be not familiar with. So I thank the organization for bringing me in today, and but also for challenging me to find a way to help you understand that if I can deliver a short message this way, you may be able to pursue your healthcare in this manner as well. So let's get into it a little bit about what telehealth is. So we know that the mother of invention is necessity. Something has driven us as an industry and as a community to try and find other ways and to get around this current obstacle. And there are lots of rehab tools that we may have at our fingertips. So I actually believe very strongly that we should not be holding our breath for the cure and the vaccine. We should not be wasting our time thinking about maybe next week it will open. Maybe we should think about that. And I do believe quite strongly that when we come back to some sense of order and normal, we'll actually come back with more tools as a result of being forced into this sort of creative opportunity. So to be honest, all of you are really untapped potential because you may not know just how many extra tools you're going to come back from when we start to think about how we can move together through this virtual medium. Go ahead, Mira. So if I look to this slide, so what is telerehabilitation? It's really delivering rehab services using internet, video conferencing. We know we can do consultations, mentoring, education. We can do a lot more. We can do functional assessment. We can do movement assessment. I've had many, many tours around people's homes in the last 3 weeks using this telehealth medium and really gain a great insight. So carry on then, thank you. Next slide. So it's an online session for sure with your clinician. It should be a safe platform. And when I say platform, historically, I would have thought of that as the 5 and 10 meter diving boards at your local swimming pool. But a platform is an electronic tool, a software program that's been written to provide a certain amount of relative security that is easily used and accessed by both the clinician and the patient. There's been a lot of work done by the people who looked at telehealth and how do we deliver this to make sure that we can guarantee patient safety and really look towards how can we make sure that the risks are managed. And so you will have consent forms, which will be something that you will have always signed a consent form when you see a physiotherapist, but now you have a consent form that says, I've got a safety person here with me. There's someone that can be called if there's something that just goes sideways during this session. The other thing that's quite interesting is that most of us in this telehealth format have found that what we achieve during our sessions becomes a bit more defined. And so sometimes when you go to the clinic, there's sort of a rhythm that you get used to. You go in and you see your physio and you talk to the reception and there's sort of a rhythm. Well, that rhythm is now being defined by what are your goals in this time together in this virtual medium. And so most of us are finding that there's an element of specificity and a real focused and practical approach. Carry on, thank you. So what do you need? Let's go back one slide. You need a computer with a camera and audio. Having said that, there are a few platforms where you could do just audio. physios really love to watch how you move. And historically, let's say 2 months ago, 3 months ago, I believed quite strongly that people saw me because I have fantastic hands and we could do lots of interaction in terms of moving, and I could cue movements. And what I realize now is that lots of it is observational. When we now are working, we're looking at how do you move. So you do need a camera and an audio in order to maximize movement assessment or to have a good look at what your space is. But you could, if it's primarily consultation or you need a little bit of motivation or regrouping on exercises that may have been working well in the past, but you just don't have the motivation. So you could get away with an audio session. Safe space is good, and I will tell you that when I have patients who are prepared with a small space, you don't need a ton of space to do your exercises. That's another thing you're going to identify as you get into this, is that there's really not, you don't need a big gym. A small space with a yoga mat, maybe some of your TheraBand, maybe a small stool or something to guarantee that you're safe moving in different positions. But what we're also identifying is that equipment needs don't have to be substantial. The latest humor I've had is having somebody slip an oven mitt onto their foot to do their foot slides. And so we had a discussion whether an oven mitt or a margarine lid slid better on the flooring surface, whether it was a vinyl flooring or a linoleum. So it's kind of fun. And I'll date myself, if you're MacGyvering your way through what works in the home in your small space to still carry out some things that you may have had some success with in the past. Carry on. So when you're on a telehealth session, so this is me, I'm sitting in front of my laptop with my webcam on the top. So this is what you would see. We use an electronic medical record platform that has been rolled out, and this is the exact screen that you'll see. I have a nice painting by my brother-in-law on the back, just so it's cheery and something to look at. But we also have the opportunity to move our camera around and be able to demonstrate and give you examples of what we might be trying to achieve. Carry on then. So why not wait? We don't know how long the modifications and restrictions are going to be. As a matter of fact, we don't know if they'll maybe happen again, and will there be another spike and fall where we need to manage and protect ourselves again. So I would argue that when patients say, well, I'll just wait, Wendy, I'll wait till things come back, I'll wait till life gets back to normal, I can't guarantee when that's going to be. We know that most of the insurers in this country have stepped up and recognized telehealth for rehabilitation, which for many people makes it affordable, makes it an opportunity that they can also then not feel like, or have an opportunity to recover their costs. I do believe that the longer the time goes, the more momentum is lost. So I think one of the things Mira mentioned initially was like bone density. I don't love the idea of my patients staying away from strength training just because they're not able to access the gym. Because what I don't want to see then is that we're now behind the 8 ball with bone density, muscle strength, contractures. It doesn't take long for those to start to become a bit more spicy, and then we have a little bit harder work to do when we get back to our environment. I think it's a fun way to learn some new skills, learn some things that you can do in your own home. So yesterday I met with a woman virtually, and we identified that her bunk beds, her kids' bunk beds, were the perfect vertical pole for her to have TheraBand attached at different heights. So she put little bits of tape along the bunk bed post, and now has a strategy for her shoulders, a strategy for her core, a strategy for her knees. And the TheraBand has its little spot on the bed. We would not have ever known that had I not walked around her home with her in her camera. And so she has a whole new set of skills because that's an exercise that now makes sense to her. She hasn't left the clinic and gone home to think, how could I do this? We've set it up in her home. So it's a whole new skill. And so that kind of innovation, I mean, I said innovation can be innovation. It's because we're trying to get some recruitment strategies, and we've done so in a way that now fits in her home. She doesn't have to try to figure that out. So my answer when patients say, well, why don't I just wait, is why not start? Let's advance the slide. And I would say, if you just try once, you have no clue how fun it can be to tour around the house with your physio. And admittedly, that does bring a level of intimacy, and you are allowing us in your home, which for some people is a very private place. So if you don't prefer and you don't feel like marching around your home or having somebody demonstrate those places and you'd like it to be in a small contained space, that's 100% respectable. But it can be fun to find those new purposes. And I would argue, try once. And if you don't feel motivated, and if you don't feel like you've regrouped a bit and maybe reprioritize some things that you can work on in this time, then you don't have to try a second time. You can tell them Wendy said once was enough. Carry on, please. So there are 3 areas that I have found that I think people are have really got to make better choices. Firstly, are you working from home? And if you're so, and this is my husband, and this is his awfully messy desk, but and he has reasonable posture. He's now got his monitor stacked up on a couple of boxes of paper and multiple screens. But what we've done is we've ensured that he's only there 1/4 of the day. So take your day, divide it into fourths, and change positions. Move to a different workstation, work from a counter standing up, maybe move around the home a little bit if you can. Change positions. And I would argue that working from your laptop on your bed is probably the most perfectly awful ergonomic reality and not ideal. Maybe it's a good rest for you. Maybe if you need to stretch your hamstrings a little bit or your hip flexors a little bit, a short session on the bed might be reasonable. But the bigger issue for me when I'm thinking about what people are doing right now is that they're working in one space for 5, 6, 7 hours. Now, the next category is, you can advance the next slide if you like, please, is play. We're super lucky this year. The weather gods have smiled favorably on the West Coast and given us a fantastic April. So it's not been difficult to get my boys out, and we ordered wiffle balls. They arrived within short order, so you can smash wiffle balls around, and the neighbor's property is all reasonably safe. Put some music on and dance. But the idea that we have to keep play. And so exercise and physio, sometimes we're also, we're science-based with our exercise prescription and we're trying to maintain function. But at the heart of sometimes what we're really trying to do is make sure that that affords you the mobility, the dexterity to still play. And that, I think, in terms of, yesterday mental health came out with some pretty staggering numbers on how many people aren't happy right now and are struggling a little bit. So perhaps I should have put dance higher and put play more important, because I think we need to do that in order to balance the sense of stress that we have going on around this. And then the last part of that is the body work. And I know that we have one speaker coming shortly who is going to talk a little bit about some good home exercises, some things that are really, reasonable to keep transitioning into your home. The one thing I would say is, if you are struggling to figure out where to start, do a session with your clinician, or at the very least, take all those pieces of paper where they've sent you, whether they do hand-drawn or videos or pictures, pick 1 or 2 and start. Don't try to feel like you need to pick all 24 exercises that you've accumulated over the last 10 years. Pick 1 or 2 good ones. And if you need help prioritizing that, let your clinician know that I really need you to just prioritize a few things for me, because I need to get some traction. I need to start building this back and recognizing that I too can do this in my own home. Carry on then. I think I've got one last slide. And then I made a list. So that's a pretty big list of things that would make for a really great physical specimen, kind of being the best form of your physical self that you can be. And I put mindfulness on that. I put recreation on that. But I would say keep it simple. Start with one thing from each category if you want. Take a look at that category and pick one thing from each of those that you've learned along the way. Set up a session with your clinician, with your physio, and say, which of those things could I do one thing of? And I think if you keep that sort of simple start, it's way easier to gain momentum, get some traction, start to see a pattern developing. And I think I'll just close with one thing, and that is that there's no question in my mind. If you are struggling to figure out how to keep this body work happening, be specific about a time of day. The more consistent you are with a time of day, the more likely it will become a pattern. And so to that, I think to that end, I'll sign off now and pass it over to Chantel. And I will, I think, be involved in some of your Q&A shortly.
Thank you so much, Wendy. So that's correct. So next we have Dr. Chantel Camden. I'm going to go ahead and stop sharing so she can upload her slides. Chantel is an associate professor at the School of Rehabilitation at Sherbrooke University in Quebec. She is a physiotherapist by background and completed her PhD in rehabilitation sciences from the University of Montreal and her postdoctoral training at CanChild. Dr. Camden's research focuses on developing, implementing, and evaluating evidence-based interventions and service delivery models for children with developmental delays or disabilities. She's also involved in using multimodal web-based services to develop services. Welcome, Dr. Camden. Go ahead and mute, and you're unmuted.
Is the sound okay?
Yes, go ahead.
Excellent. Thank you so much for the invitation. And thank you so much, Wendy, for the great talk. I really liked how you actually asked why not start now. And hopefully lots of you are now saying, seems that it could be fun, but is it effective? And this is actually what we'll be looking together. And you will see that tele-rehabilitation, either for children or adults with disabilities, can both be fun and effective. So when we talk about effectiveness, it's really about the scientific evidence. So looking at research, and this is what we'll be doing together in the first section of this presentation, but it's also grounded into clinical or personal experience. So now normally when we talk about evidence-based practice, it's also about patient preference, but I would argue that nowadays with the COVID, it's also about feasibility. So tele-rehabilitation has just seen just an increase in interest because now we are looking for alternative to face-to-face. And the good news is that we actually have effective, fun alternative to face-to-face interventions. So the results that I want to share with you with regards to the scientific evidence is actually are based from a very timely literature review we conducted just a few months ago, and the paper is available. But what really I wanted to discuss with you is, although there's no actually study that we included that were really specifically about children with muscular dystrophy, because we were looking at children in general having different kind of disabilities, nothing was specific to muscular dystrophy. But lots of relevant information was included into different articles that we included. So basically what it means is that it's not that there is no scientific evidence for tele-rehabilitation for children with muscular dystrophy, for instance, because there are some papers that are published, but were not necessarily included for different methods reasons with regards to the quality or the rigor of the research, but really it's just because evidence are emerging, and we will see just a huge spark and an increase in the quantity of evidence we'll have in the next coming years, just because there's so much going on now in terms of tele-rehabilitation research. But again, nothing is specific to children with muscular dystrophy, but lots, as you will see, is applicable. So quickly, what we have seen is that tele-rehabilitation can be effective for lots of different populations, children and adults. In my case, we are looking more at children, but also there is a diversity of tele-intervention characteristics. So lots of different type of intervention. So when they really discuss a little bit more about perhaps what we would call video conferencing, where you actually see the patient and the therapist interacting together, but there is also different ways of providing intervention at distance. So phone calls, which is actually just using the audio for certain objectives or treatment goals, it could work very well. Reading information online, sending information by emails, using video recording, using forums. So in the middle, it's like forum, which is basically what an online forum is. It's something like the equivalent of a group intervention, but is in an asynchronous online format. So again, there's a great diversity of tele-intervention characteristics. And the good news, again, is that all these different type of intervention can be effective depending what are your treatment goals. And with regards to treatment goals or intervention objectives or what you, for instance, as the family want to achieve, again, the good news is that there's lots that can be addressed and achieved through tele-rehabilitation. So we do have evidence that we can use tele-rehabilitation to have positive impact on children's behavior, on parents' behavior too. So in terms of interactions, knowledge, skills to interact with the child, for instance. It's effective on decreasing symptoms, improving communication, improving functional skills and motor skills too. So for instance, increasing strength, the ability to move around. So really, basically what the slide shows is that tele-rehabilitation can be used to achieve a variety of different goals that you want to achieve. And we do have scientific evidence to support that. Now, what we have looked at too is we were trying to really understand if we want to design the most effective tele-rehabilitation intervention, how should we design this intervention? So what we did is to look at where we had more evidence or how the characteristics of the intervention were designed, how it's related to greater change in outcomes. Now it seems that behavioral objectives are easier to attain online. And this is based really, again, just on the science, so on the research evidence that we have. And it might be intuitive because it's easier perhaps to change parents or children's behavior than some things that might require a little bit more hands-on. With children, when the intervention is centered on the parents as opposed to interacting on focusing mostly on the child, seems to be more effective. But there's somehow like a specific program to follow, so some guidelines about how the intervention will work when we use a coaching approach too. So this is this idea of collaborating together, interacting, problem solving together, as opposed to just providing passively information. There's something else around dosage. So when there's some frequency, so at least once a week for 8 weeks or more, this is to be interpreted with caution, because again, the idea is to get started, and you might want to have just one-time consultation to review your exercise programs, and it could be very effective. But again, within this idea of what are the most effective characteristics, when there's some continuity of care or some continuous interactions, it seems to be a little bit more effective. And the last one, really, what we were looking at wasn't specifically for physios, but really in rehabilitation in general. And what we found is that intervention where a psychologist was involved tended to be a little bit more effective. Now, this needs to be interpreted with caution because, again, the state of the evidence is just emerging in the literature, and it probably relates to the fact that behavioral objective thus far seems to be better achieved by the kind of tele-rehabilitation intervention that have been tested through research, but also because we have lots of evidence in children that comes from children with autism, and lots were around behavioral objectives, and psychologists were involved. So, but basically we do have evidence that support the use of tele-rehabilitation for physios as well as any other rehabilitation professionals. So I would say that the question now is really not, is tele-rehabilitation effective for children with disabilities, or same for adults with disabilities, or specifically in muscular dystrophy. But really, it is effective. What we need to better understand is for whom is it the most effective, for what objectives. So as the slide showed, like tele-rehabilitation can just address so many different goals, but really to better understand how we need to tailor to develop the interventions really best achieve the different objectives. This is where we actually need more evidence, but really we do have enough evidence to really say that tele-rehabilitation is effective. So now if I just share with you a little bit more about my own experience, where we have been using tele-rehabilitation for about 5 years, mostly in a research context, but again, providing clinical services, there's probably things that are best done face-to-face, things that can be done either way, and things that can be done online. But now, and this is goes back to this idea of feasibility in the context of the COVID, there is really a push currently to do more things online. And this is actually probably a great thing in a sense that when they ask, why not start now? We have enough evidence that tele-rehabilitation is effective. We knew it was a behavioral change for clients, for therapists, but the COVID is also an opportunity to start doing things differently that might be even more effective and more fun in an online context. And as you will see, perhaps also more accessible in terms of travel time, geography, just being accessing, for instance, information online or doing some program whenever you do want and have time. So obviously there's things probably that cannot be done face-to-face because of safety issues, because of equipment requirement or else. But again, I would argue back that there's lots of things that a little bit of creativity, we can replace equipment that we have in specialized clinics by equipment you can find at home, or things that you cannot do perhaps hands-on, but through a coaching approach or like interacting with your therapist or between the therapist and the clients, you will find ideas to actually achieve the goal. So really the focus is not on what you normally do, but what was the goal? Why were you doing this? And how could you do it differently so it could actually be done online? So in a nutshell, really having good relationships between families, children, adults, and therapists is really key, just as it is in face-to-face interventions, and really having very clear objectives. And Wendy talked beautifully about that. So making sure what's the plan actually, and tailoring services to meet the goals. And being able also to offer timely responses to families' concrete needs. So really the intervention need to be grounded in families or children's or adults' concrete needs to really support them self-managing, implementing their own program, responding to their questions and concerns. And this is best achieved using sharing information, but really using this coaching problem-solving approach, which is really collaborative and where you actually look at finding ways to actually improve the day-to-day life together. And obviously a variety of technological modalities. So yes, internet, yes, computers, but there are just so many different ways also thinking about sharing videos by email, photos, phone calls. So again, depending your access to technology, but also your ability with the technology, and as needed, just if you require support, just finding ways to actually have the support to access this technology. And this is my last slide, actually. So I was just trying for fun to come up with a nice acronym around tele-rehabilitation. And when we talk about virtual, really, there are just so much things that is about viewing. And again, Wendy discussed that. So there's so many things that we as therapists can observe through video conferencing, through photos, through videos, that will actually help and support this coaching approach to work together to achieve different goals. And I stands for information. There's lots of things that can be achieved just by sharing, providing the good information just in time. So what do you need, perhaps as a parent or as an individual with muscular dystrophy, and actually sharing your information needs with therapists. Information is just so easy to share through tele-rehabilitation in different ways, written, through video conferencing. So really thinking about information needs. Relationships, making sure that the intervention is grounded into good relationships, and this idea of collaborating together to build capacity, and ask therapists to act as a coach, really working again collaboratively. And T stands for technology, obviously, because this is key. And when we talk about providing intervention at distance, so we need to be ready and comfortable using the technology. But I would argue back also that we need to just give it a try and learn and have fun actually learning this new way of probably doing rehabilitation. Remembering that all families are unique, so you are unique and you have probably very specific needs. So even if we as therapists sometimes design very specific structured program interventions, just don't hesitate to share what are your specific needs and to actually problem solve again and find new ideas, use creativity to find ways to work together at distance to meet your goals. With regards to access to services, and this is perhaps a little bit more for, I think that actually the big plus is for families because accessing telerehabilitation is just so easy. It can be done from anywhere at any time. But for therapists and managers, I would also encourage us to really think about how virtual services are accessible to all. So this is why I would encourage probably some therapists to think also about just giving a phone call if families are not comfortable with computer and thinking about who are we not reaching by providing telerehabilitation services, just to make sure that we think about equity in access of services too. And don't forget legal issues and confidentiality. Face-to-face, online intervention, the legal issues and consideration are just the same. So just a big thank you to for the invitation again to be with you today, to my team who is just fantastic and I have lots of fun working with them, and to the funders who have made this research program on telerehabilitation possible. And we're looking forward for questions and comments at the end of this session. So thank you so much, and I'm just gonna stop sharing my slide and it's back to you, Amira.
Excellent. Thank you very much, Dr. Camden. Next, we have Virginia Kudritsi. Virginia received her Bachelor of Science in Kinesiology from San Francisco State University and her doctorate in physical therapy at the University of Montana. She's devoted to caring for veterans and has worked her entire career at the Seattle Veterans Hospital. She has 11 years of experience caring for persons with neuromuscular disease in both inpatient and outpatient settings. Her professional interest lies in promoting safe exercise and mobility for persons with neuromuscular disease. She's currently collaborating on a grant focused on expanding telehealth-based physical therapy to persons with neuromuscular disease. Virginia currently is the lead physical therapist on the Seattle VA, MS, and ALS interdisciplinary teams. Welcome, Dr. Kudritsi.
For this panel. My favorite professor one of my favorite professors in college was my chemistry professor, and one of the things that he loved to remind us is that repetition is the mother of retention. So what you'll see is that there's a lot of actual overlap between Wendy and I's presentation, so I'll try to keep the overlapped areas brief. Just as a disclaimer, you know, as a physical therapist working in the VA, in a VA hospital, the average age of my patients are in their young 60s. So again, I don't have much or really any at all work with the pediatrics. In pediatrics, we here at the VA really stopped all in-person or face-to-face visits about a month ago. So we were doing all televisits and telephone visits. And there's been no doubt a steep learning curve for all of us, patients and providers. By the end of my brief presentation, I hope that you can answer the following questions. Physical therapy and telehealth, what does the evidence show? What does a tele-PT session look like? What can be done with a tele-PT visit? And what can you do if you don't have access to tele-PT? In very general terms, research on physical therapy, specifically exercise for individuals with neuromuscular disorders shows that exercise is not only safe, but is incredibly important in maintaining and improving quality of life as well as well-being. Of course, there's a caveat here that I want to point out that individuals who choose to move forward with exercise should get cleared by their doctor, and ideally the program is prescribed by a skilled physical therapist. Next slide, thank you. So general research findings for telehealth physical therapy in the neuromuscular disorders population. Unfortunately, the research is quite limited. what we can do instead is kind of extrapolate from the research of other diagnoses that have shown that telerehab is not only as effective as in-person rehab, it improves functional independence, cognition, and patient satisfaction, and can be beneficial, cost-effective, and satisfactory for patients and providers. So what you'll see on this next slide, go ahead and move forward, is that you've seen this picture before. Thank you, Wendy. Just a very basic shot of a telehealth presentation with the PT patient and a very large computer. Next slide. Again, the necessary components have already been touched on nicely by Wendy. I just want to stress two things, at least here in the States. Not all telehealth visits are supported by all healthcare systems, so making sure that your healthcare insurance covers it so that our providers can be reimbursed is always important. We have free reign here, part of the VA system, so I am really allowed to treat any veteran across the United States, which is fantastic. I actually treated a veteran up in Canada, built a custom wheelchair for him a couple weeks ago, so that was pretty cool. And then also an emergency plan, making sure that someone else is either in the home and we know of that person, we know their name, and then making sure to confirm your physical address and your phone number so that, heaven forbid, anything happen, that we can relay that information correctly to emergency personnel. While this is not necessary, these are recommended components of a telehealth visit. So having a caregiver, family member, or what we call a telepresenter there to help facilitate the session is always beneficial. Having an open space, or at least a big enough space to move around in, and having a secure space so that the patient's privacy is protected, or your privacy is protected. And then having any mobility device present. So if you typically walk with a cane, crutch, walker, or use a wheelchair, by all means have that ready to be used so we can see how you use it. And then a gait belt or a transfer belt, depending on what word you use to describe it, is great for protecting people from falls. Typically during the first telehealth visit, the PT will perform an evaluation of the patient. Physical therapists like to practice patient-centered care, and in order to do that, we need to identify specific patient characteristics that we can base our interventions around. Tons and tons of questions, which are going to include stuff about your home environment. Are there stairs to access your home? Are the hallways narrow? Who's around to help you? Is there a significant other? Is there a child? Is there a paid caregiver? Your current and prior level of function and fall history. And then if the need for physical therapy is more based on orthopedic issues or vestibular issues, like you're dizzy, or pelvic floor issues, we're going to be inquiring about those issues as well. The physical aspect of the evaluation will do stuff like testing your strength, your range of motion, your balance, coordination, and sensation to the extent that we can. And then for a more gross motor perspective, seeing you move within your home, in other words, assess your functional mobility. So once the evaluation has been completed, a physical therapy plan of care can be created, which can include tons of services and resources, not just exercise. Pardon me. Functional mobility training is our term kind of used to describe gross movements such as getting in and out of bed, transitioning from one surface to the other, what we call transfers, walking, stair negotiation, even going outdoors and seeing, how you move around in your community. We will walk you through valuable exercises during a telehealth visit and provide a home exercise program when appropriate to do on your own, whether alone or with a caregiver, that again addresses deficits in strength and balance and coordination. And then tons and tons and tons of patient education. Next slide. In addition, what we can do is we can teach your caregivers and family members how to use equipment that helps mobilize you safely, such as a lift system, and provide you, or teach them how to provide assistance during your mobility, like how to get out of bed, and then biomechanics, teaching your significant other how to safely mobilize you without hurting themselves. During an eval or even during a treatment session, we can identify equipment needs. Here at the VA, we're really fortunate. We can just literally ship it out and then do the training and fitting over a telehealth visit. We can identify the need for repairs or modifications. As I just said, I just had a wife measure her husband for a custom wheelchair up there in Canada. That was great. It's coming right from Motion Composites, which will be next door to him. And then home evals are commonly provided too, to assure your safety in your home. So during a home eval, the therapist will actually see your home rather than relying on a subjective report from what you're providing in an eval, and how you move within your home. Wendy pointed out nicely how creative physical therapists can be in providing you resistance for exercises. You know, some of the things that we learn in PT school are just very silly things, like a soup can is super light. It's like, what, less than 2 pounds. A jug of milk can provide resistance for exercise. A broomstick can help stretching your upper extremities. So we can be creative in providing you the appropriate exercise to address your deficits. Again, a gaiter transfer belt, mobility aids, computers, all necessary equipment. And then in general, and again, some of this has already been stated before, but there are many benefits to telephysical therapy sessions, especially for those living in rural environments where providers are limited. Tele-PT visits decrease the financial, logistical, and physical barriers of getting to a visit. I believe that actually performing the exercise or the mobility repeatedly in your home is of more value because it's practiced in real life environments and situations. We as the PT evaluating your home can actually see it. Again, not base everything on people's reports. And then really important during these times, a telehealth visit is really going to keep you more safe and decrease the risk of transmission of the COVID-19. Everything has its barriers and limitations. So at a tele-PT, the barriers and limitations of a tele-PT visit is that it requires that individuals have relatively good understanding of technology. So patients and providers with limited technology experience can really struggle with the visit, or a lot of our older vets, they just completely opt out of it and just ask to wait. I would encourage you to at least try, or at least try via telephone. A physical therapist really wants to see many perspectives, not only of the patient, but of a home. And sometimes that's not possible, especially if the patient lives by themselves. Limited space, so if you do have a crowded home or you have a smaller home, sometimes we can't quite see how well you can move, or it really may limit how much you can improve. But again, not a reason to opt out by all means. More than often than not, people don't have treadmills or recumbent bikes in their home. So if you have a need for cardiovascular exercise, that PTs will definitely have to be creative in finding ways to get your heart rate up and keep it up for a prolonged period of time. And then physical therapy is typically a very hands-on service. If we aren't guarding or providing assistance, we may be facilitating proper movement through tactile cues, tapping or squeezing muscles. There's a whole bunch of different tricks in our bank to help get muscles to fire appropriately. So this obviously cannot be provided during the telehealth visit. Just to wrap up, what I would like to provide are just some very simple, safe exercises one can do. But again, please clear it with your doctor. If you have access to telehealth PT, have the PT agree with these or create their own program. And so I'm just going to quickly flip through these. So bridges or sit to stands, one of my favorite exercises is I feel that this is one of the most effective and easiest exercise one can do to maintain strength in your thighs and your bottom, and it translates very, very well to function. I read an article many, many years ago that I believe said, I always like to screw the numbers up, that if one did about 15 to 17 more sit to stands a day than what their day typically called for, that they saw significant improvement in people's function and quality of life. I mean, everyone has a chair in their house, and if you're able to do it safely, by all means, it is a great exercise. Next exercise is hip abduction. In other words, kind of swinging the leg out to the side, whether with standing, you can be on your side, you can even be on your back. This exercise targets a muscle that is very important, that is in your hip, that is very important for stabilizing the pelvis during walking and preventing falls. Next one is heel raises, which targets the calf muscle. So the calf muscle is the second biggest pump in your body behind your heart. So when we become sedentary or we sit a lot if we're in a wheelchair a lot, keeping the calf strong can help promote good circulation. Naturally, gravity wants to pull. Next exercise. Go ahead and move forward one. Thank you. Naturally, gravity kind of wants to pull around our back and pull our shoulders forward. So exercises that promote stretching of the chest wall and strengthening of the upper back are good to promote exercise and good health of the spine. and shoulders. So shoulder blade squeezes or backwards arm circles. And then finally, last exercise are chair press-ups. Another great functional exercise that we can do relatively easily at home, don't need any equipment for it, to keep the upper extremities and your upper back strong. When I was a young brat, I used to love to make faces at my mom, and she would tell me, you continue to do that, you're going to look like that permanently. So there is actually some truth in that. If we constantly sit in a chair, we will actually start to look like a chair. So 5 simple stretches to keep you limber and not looking like a chair. Hip flexor stretch, so the muscle in front of your hip, keeping that limber. I'm just going to quickly go through these. Calf stretch, one of the first muscles I see contractures in the neuromuscular population. So keeping your calf limber, whether you do it or you have a family member do it. Hamstring stretch, the tissues behind your knees can easily bind down, decreasing range of motion and impairing function. Stretching your chest wall with a wheelchair wall stretch, promotes good posture and shoulder health. And chin tucks, everyone should be doing these no matter what's going on with you, all day, every day. It's going to help promote good hygiene of your neck, good posture, and decrease or prevent pain. In conclusion, I'm so sorry if I totally went very quickly through that. Exercise and staying active is safe and important for individuals with neuromuscular disorders. Telephysical therapy or telehealth physical therapy has been effective at delivering physical therapy services that are typically provided in person and is more cost effective. And there are an abundance of services that we can offer through PT visits. By all means, please stay safe, stay active, stretch, and thank you.
Thank you very much. That was excellent. So next we have our live Q&A. I see some questions coming in, but I also want to introduce Jaylee Pelletier, who's here today to help provide guidance on these questions alongside our panelists. Jaylee is a physiotherapy, occupational therapy assistant, and she's living with a neuromuscular disorder, CMT syndrome. She attended College Boreal in Sudbury for the occupational therapy and physical therapy assistant program. She wants to help others stay motivated and active during this time. We are also really appreciative of Jaylee, as she's a longtime supporter of MDC and was the ambassador for the 2019 Muscular Dystrophy Canada North Bay Area Walk. So as a reminder, go ahead and submit your questions in that chat box. I'm going to go ahead and read one of the questions that's come in. Is there any neuromuscular condition for which these exercises would not be recommended? Heather's saying that she has an undiagnosed, likely neuromuscular junction disorder where any repetitive movement creates long-term fatigue. Jaylee or one of our panelists, do you want to speak to that question? Let me just make sure everyone's unmuted. Sorry, Wendy.
This is Virginia. Yes, absolutely. I think that there are, I mean, as the website says, for Muscular Dystrophy of Canada, you guys deal with 160, I believe is the number of different disorders. And a lot of them have unique characteristics. Can you guys hear me okay?
Yes.
And so again, back to that, having your doctor clear you for exercise is important, and having the prescription of exercise done by a skilled physical therapist. When I was speaking with my coworker, Dr. Ileana Howard, who was unable to be here, I took her spot. She was saying, "Oh my goodness, like you have heel rises, and there's one of your exercises." I think she said Duchenne's. That is not indicated. So there are definitely exercises that are not indicated for particular diseases. Fatigue, I see fatigue a ton, of course, in my ALS population. In my MS population, fatigue is not a contraindication to exercise. If anything, what it is it's a it is a symptom that we need to manage and pay very close attention to. My exercise handout that I provide all of my people with Lou Gehrig's disease says your exercise program should be modified or stopped if it causes excessive fatigue, if it causes fatigue that lasts more than normal, and I think most importantly, fatigue that prevents you from doing the things that matter more in life. So my older veterans, when I tell them, if you've done my exercise program and you are so tired you cannot, one, communicate, you cannot eat, you cannot play with your grandkids, by all means, please stop it or back way down. So I hope fatigue is not keeping you from exercise, but by all means, speak with your doctor, get some PT advice, further PT advice, be safe.
Great. Prior to today's webinar, we also received this question. Someone mentioned that they have an 8-year-old boy with Duchenne muscular dystrophy, and ever since COVID, he is certainly out of his routine and has been eating differently and also has completely stopped any PT. He's gained 11 pounds, which is concerning for the family. They were wondering if there's any suggestions on how to get him to exercise and motivate him. Jaylee, do you have any tips for this family?
As they were saying prior to, like, you'd be kind of shocked how many things at home you could use as exercises if you don't have TheraBands or dumbbells. You could definitely use some towels to do some strengthening as well as some stretches. You could use, if you ever have tension, you can use a roll pin to release the tension in your muscles. As for motivation, for me, I just crank up that music, dance along, do the exercise along to that music. But also, as they were saying, it's very important not to overdo yourself in your exercise, as you can become fatigued, and as you get better, to add those repetitions and give yourself more and more exercises. But do talk with your physiotherapist what exercises you can and cannot do.
That's great, Jaylee. We have another question here. My 5-year-old has SMA, spinal muscular atrophy, and I'm concerned she's losing the gains she made in physio in terms of maintaining her balance and standing independently. We had some suggestions about this, but what can we do in the home to help her? Do you want to try that, Jaylee or Wendy? Virginia?
I'll say, okay, sorry.
Go ahead, Jaylee, go ahead.
Well, definitely for balancing and standing independently, we could do balance exercise with, of course, with someone there to be able to watch you, such as, it's hard to explain when you can't see me, but definitely some just walking on foot on place to help with your balance. Strengthening as well could help with the balance. If anyone wants to add.
Great. I also see Diane Davidson, who is a long-term supporter also of Muscular Dystrophy Canada, and she's a PT with OPMD. She mentioned that trying to make the activity fun for the 8-year-old would be really good in this scenario. So
My thoughts are as well that with a 5-year-old, I think that if you can have your child and have her, I mean, I would argue Dora the Explorer, and trying to mimic some of the actions Dora's doing, if she's standing in front of a chair or a small ottoman, something soft. But I would actually use video and use mimicking and doing some of those balancing and independent standing activities with a figure or a show or a character that gets her excited, makes her smile. I think that then sometimes mimicking is a really fantastic way, because the other part of that whole balance exercise is that it's not about necessarily deeply focusing, it's about maintaining some of those reflexes and those strategies when our brain is occupied and our eyes are occupied by something else. So that's one of the things I would try.
Thanks, Jaylee. Thanks, Wendy. How about we just take this one last question? I have myotonic dystrophy, and my PT asked me to order a fitness physio seated elliptical trainer now that they're home. Any evidence that this equipment would be helpful?
And can you get your hands on it right now? One of the things that we've discovered is that a lot of fitness equipment is so back ordered. That's one of my biggest concerns now, is getting your hands on something and having it delivered. So right. My first concern is just how little equipment is out there right now.
Great point. Thanks so much, Wendy. So I want to be mindful of time, and I know we're 2 minutes over. So to end today's webinar, I want to thank all of you, our special speakers, for sharing their insights, and to our mission team at Muscular Dystrophy Canada for their ongoing work in supporting individuals in our neuromuscular community. As always, I'll post top 5 key learnings from this webinar, and I mentioned that the recording will also be available on our YouTube page. At any time, if you have any questions, please email research@musculardystrophy.ca muscle.ca or give us a call. We'd be happy to help. And as always, thank you so much for joining us, and we'll see you all next week. Thank you.